Dr. McCloskey, if you see such a patient, what are the treatment options you're thinking of? This is a 70-year-old and has a known diagnosis now of AML MRC.
Yeah, so I think that this is a patient that we would certainly easily identify as a high-risk patient. It's an older patient, but seems pretty fit. Comes with some adverse cytogenetic abnormalities and has already received prior hypomethylator. So this is a patient who certainly is at high risk from complications from their disease and requires us probably have a long conversation about the fact that this is high-risk disease and that even with all of the treatment options at our disposal, their prognosis is poor, and kind of what are their priorities, what are the important to them from a quality of life standpoint. But in general, for a patient who's fit, who is eligible and interested in intensive chemotherapy, this is a patient that we would treat with Vyxeos. And I think, again, when I sat down with that patient, my conversation would be that with them that we really do have randomized phase 3 clinical data to kind of support the use of this drug for this particular patient with AML rising from a prior hematologic malignancy like this.
Yeah. And now about Vyxeos, so are you doing this routinely inpatient, outpatient to start the treatment? People do it differently. What has been your practice? And then also maybe Dr. Gerges and Rizzieri, what do you do?
So I think we were very fortunate to be involved with the phase 2 and 3 clinical trials with Vyxeos. And in the phase 3 study, we were actually very conservative. We treated all of our patients during induction and consolidation inpatient. But the drug is a 90-minute infusion, as we're going to talk about, days 1, 3, and 5. So it immediately raised the possibility that this could be delivered outpatient instead of a continuous IV infusion like we use in 7+3. For us, like many of my colleagues, we're fortunate to have a very large infusion center. We have a large transplant program, so we're able to kind of support our patients outpatient. And we actually had already piloted an early discharge program with 7+3. So once the drug was commercially approved, we put in place a protocol to kind of select patients that might be eligible for outpatient induction. And this included things like living in close proximity to the hospital, having a caregiver, not having certain other comorbidities, and then for us to kind of hold a bed actually in the hospital that we often share with our transplant teams that we felt we could reliably bypass the ER. And it has been feasible for us. I would say that most of our patients actually are still treated inpatient, and that's often their preference because patients, are often quite, taken aback with this new diagnosis and feel more comfortable being in the hospital. But it is feasible, I think, with great caution and understanding that these patients require a lot of support while they're outside the hospital.
Yeah. What about you, Dr. Gerges and Rizzieri? What are you?
Just like Dr. McCloskey mentioned, so the initial induction chemotherapy, we prefer to be inpatient. After all, these patients have a 10% mortality in the first month or so. In the phase 3 clinical trials, half the patients received the drug in the consultation as an outpatient. So we follow this. For a patient like this with low white count, low disease burden, if this patient lives, my institution is in Manhattan, if this patient lives in the Upper East Side with an infusion unit that we have open almost 16 hours a day, and the right patient, we can even do the induction. And especially this patient is probably known to us, had this diagnosis, MDS, for a year and a half. So in a few patients, we have done even the induction as an outpatient.
It's in the minority, but...
And the minority, of course.
In general, inpatient. Anything different, Dave?
I think I would echo that. I do think with our emerging understanding of the biology and the impact of the maybe supplementary things to the diagnosis and chemotherapy that may impact outcome, I would expect more and more outpatient in the coming decade. As an example, number one, what is the impact of exercise for the patient's recovery and the impact on disease? And that's an emerging area of research that I think may be important. And I think of the outpatient setting is tougher for our patients. As we know, they have to get up every day, they've got to get back and forth to the center. That by itself is exercise. And so I think that's important. And the other aspect is the impact on the microbiota of being outpatient versus inpatient. And of course, the emerging data on minimizing the perturbations in the microbiota may be very important to both response and other toxicities. So I think there may be a significant push in the future as we understand those factors more to do more outpatient. When feasible.